Hi everyone, it's Dr. Custer here. Today we're going to do a lecture on sensitivity and specificity and predictive value. So let's get started. My usual disclaimers. I'm not a statistician. I understand statistics a little bit and am relaying the information to you. This video is for educational use only and is not intended to be sold. I love to collaborate, so please email me for any project collaboration, and I don't have any other disclosures. Alright, so goals for today. We're going to do a review of sensitivity, specificity, positive predictive value, and negative predictive value. So sensitivity. I know everyone's afraid of this stuff. Sensitivity is the proportion of disease subjects who test positive for that disease. So it's the number of people who have the condition and they test positive for that condition out of all the people who have it. And there's this formula, which I can't stand. So let's just look at this chart here, this 2x2 table. Sensitivity is talking about patients or subjects with the condition. So you only have to concern yourself right now with this column. And simply, if you have the condition and you test positive, that's your sensitivity, that's your true positive. So you want to know how much true positives over all people that have the condition. So sensitivity is A over A plus C. Specificity, on the other hand, is the proportion of disease-free subjects who test negative for the disease, so like the opposite of what we're talking about. This, of course, is the number of people who do not have a condition and test negative for that condition, which is true negative, out of all the people without it. And here's the formula again. And so for this case, for specificity, we're talking about all the subjects without the condition. And we're just saying how many patients who don't have the condition also tested negative, aka a true negative. So therefore we're looking at D over B plus D. So sensitivity and specificity are measures of diagnostic test validity, or basically any exam has this: physical exam, lab work. Screening test, you want a high sensitivity, which would mean a negative result would rule out the disease. And then for a confirmatory test, you would want a high specificity, meaning a positive result would rule in the disease. And so the residents taught me spin and snout. So SP for specificity, if you test positive, that rules in, and then snout, SN for sensitivity, if it's negative, it rules out. So a diagnostic test with perfect validity would have a sensitivity specificity of 1.0, meaning it's perfectly valid. In reality, that's not the case. Usually you have a higher sensitivity, you have a lower specificity, and vice versa. So here's a chart. Imagine these are the results of a serum marker for cancer in the general population. So over here we have our negative patients. These are the patients who do not have cancer. And so out of these patients, the ones that tested negative, the healthy patients, would be here, and this is your true negative curve. Now out of the patients who do have cancer, and we're looking at the diseased curve here, all the patients here would be true positives. So you can see how it overlaps. Of course, we don't have a true positive, true negative of 1.0. We have a trade-off rather. So you'll always see some false negatives and some false positives. So I just wanted to go over the 2x2 table again. I always think of it as this way: condition, no condition, positive, negative. Of course, I'm a math geek, so I think of it as true positives make a positive, true negatives make a positive. So these are your true things. These are your true positives and true negatives. And then these are obviously your false. All right, sensitivity. Let's do a question. A new diagnostic test for tuberculosis has a sensitivity of 90% and specificity of 95%. If applied to a population of 100,000 patients in which the prevalence of TB was 1%, how many false negative results would you expect? So here's your answer choices. All right, so we're going to work through this together. So we have a population of 100,000, and we see that the prevalence of TB is 1%. So the total number of patients with TB is 1,000. And so we can obviously do math and figure out that no TB is 99,000. And then we see the sensitivity. The sensitivity is 90%. So 90% of 1,000 is 900. And then doing the math, that's 100. And then the specificity is 95%. So this darn mouse, 95% of 99,000 is 94,050. And then we go here and we get the difference for this. And then simply you would just add across for your totals in this column. So what are they asking? How many false negative results would you expect? So we know from our 2x2 table with my crazy mouse, this is true negatives, and this would be false negatives. So the answer is 100. All right, let's do another question. Suppose the prevalence of coronary heart disease among older adults is 25%. In 100 patients undergoing angiography, blockage is found in 15 patients with known CHD and 15 patients with no previous CHD. In addition, no blockage was found in 10 patients with a history of CHD and 60 patients with no history. What are the sensitivity and specificity of this test? So here's our answer choices. I know, a lot of math, right? Let's break out our 2x2. So there's 100 patients total, and we know the prevalence is 25%. So there'll be 25% of 100 patients with CHD is 25, and then 75 have no CHD. And then here in the problem, it gives us quite a bit of detail. We don't have to do much math, just fill in the chart. Blockage is found in 15 patients with known and 15 patients without. So blockage is obviously the positive test. And here we can fill in 15, 15. In addition, no blockage, which is negative, is found in 10 patients with a history and 60 without. So here we're just going to put the 10 and 60. And then I just add across for completeness. So they want to know the sensitivity and specificity. So remember, sensitivity is your true positives over all patients with the disease. So it's 15 over 25. And then specificity would be your true negatives over all patients without the disease, the negatives. So that would be 60 over 75. And so the answer would be 60% and 80%. All right, one more quick problem on sensitivity and specificity. Below are some hypothetical results from women who had a mammogram. What is the sensitivity of the mammogram and what is the specificity? All right, so there's 1,000 women and 100 have breast cancer. 70 patients with breast cancer tested positive, and 720 tested negative that did not have breast cancer. So the sensitivity and specificity. Remember, sensitivity is our true positives over everyone with the disease. So we see 70 over 100. And then our specificity is the true negatives over everyone that's negative. So that would be 720 over 900. So the answer is 70%, 80%. All right, let's move on to predictive value. This is an important measure of the post-test probability of disease. Positive predictive value is the probability that subjects with a positive screening truly have the disease. And so let's look at our chart here. So probability of subjects with a positive screening test truly having the disease. So we're looking, this crazy mouse. We're looking at the positive tests here for positive predictive value. So how many patients that tested positive truly had the disease? So it would be your true positives again here over all positives. So another way of thinking of it is how likely is it that this patient has the disease given that the test result is positive? Now, negative predictive value is the probability that subjects with a negative screening test truly do not have the disease. And here's our formula. And so we're talking about negative tests here. Okay, so how many patients tested negative, true negative, out of all the negatives? So here we'll be doing our D over C plus D. And another way, again, of thinking of this is how likely is it that this patient does not have the disease given that the test result is negative? So sensitivity, specificity, positive predictive value, negative predictive value. Now, predictive value, unlike sensitivity and specificity, depends on the prevalence of the disease in the population tested. So if your prevalence is high, your positive predictive value is high because there's more people with the disease, obviously. If your prevalence is low, your negative predictive value will be high because there are more people without the disease. So here's just a chart assuming a sensitivity of 80% and a specificity of 90%. And this is just going to show you, based on the prevalence, as the prevalence increases, what that does to both positive predictive value and then the negative predictive value. All right, question. A 65-year-old Caucasian male presents to the office with a thyroid nodule. After the appropriate workup, a fine needle aspiration is performed. The FNA result is negative. The patient asks, what are the chances that I really don't have cancer? You respond that the probability of cancer is low in his case because fine needle aspiration has a high what? So we just kind of went over this. But this is something that is important to understand because your patients are going to come in and ask you this. And again, like we talked about, the fine needle aspiration has a high negative predictive value, which means that there's a high probability that the patient does not have the disease. All right. Another question. In a group of 100 pregnant women tested for gestational diabetes, 20 have the disease and 80 did not. The sensitivity of the test is 80% and the specificity is 60%. Based on this information, what is the PPV and NPV? So here's our chart. We're just going to fill it out like we did before. There's 100 women, and we know 20 had the disease and 80 did not. Now remember, the sensitivity of the test is 80%. So we would have 80% of 20 here, which is 16. And then the specificity is 60%. So 60% of 80 is 48. And then I just do the math for the rest. And then you add across and you have this. So there's our formulas and there's our choices. So the positive predictive value would be the number of positive tests of people who indeed had the condition, excuse me, I'm having a brain fart, over the total number of positive tests. So that would be 16 over 48. And the negative predictive value would be the negative test truly negative over the total negative tests. So that would be 48 over 52. And so the answer is 33% and 92%. All right, let's take a look at another example. And in this case, we're going to look at and see how prevalence affects predictive value. All right, in another group of 100 pregnant women tested for gestational diabetes, 40 had the disease and 60 did not. Sensitivity of the test is 80% and the specificity is 60%. Based on this information, what is the positive and negative predictive value of the test? So just like the last problem, but in this case, double the amount of women have the disease. So we're looking at increased prevalence. So we know we have 100, and this time 40 have the disease and 60 did not. So just like before, we have sensitivity of 80%, 80% of 40, I gotta find my mouse here, is 32, and then we just do the math for the 8, and then we know the specificity is 60%, so we know 36 are negative, and then the math again shows 24. And then you just kind of bring that math over, and that's that. So here's our formulas just to remind you, and here's our answer choices. So here we look for our positive predictive value. We have 32 positives over 56 total, and for our negative predictive, we have 36 negatives over 44 total. So that works out to be 57% and 82%. So now you can see by doubling the prevalence, our positive predictive value increased and our negative predictive value decreased. All right, so that's our lecture for today. As always, please contact me if you have any questions. I prefer text or email. And you can go ahead and go back to New Innovations and get the link to your post-lesson quiz.